All right. Hi, everybody. My name's Kate Kelly. I am the host of tonight's Advocacy Grand Rounds. I'm just going to slide share our program for this evening. We're joined by Len Nichols and Marlou, who is our program manager. So at Access to Affordable Care, Impact Area of Doctors for America. So I'm going to share my screen and start with the presentation. We're so glad you all are here. Um, so I will do this slideshow. All right. So thank you all for coming. We're really happy for you to all take time out of your busy schedule to join us for our Advocacy Grand Rounds. This Advocacy Grand Rounds is patient over profits addressing greed in healthcare. Just really quick to run through the agenda. We'll do welcome introductions. We'll have a presentation and then we'll have plenty of time for audience Q&A. So there's a Q&A function within this webinar. I encourage you all to use it. We will try to get through all of your questions and answers as soon as we can. And then we'll have a closing. A couple reminders before we get started. This is a Doctors for America session. We will be recording this session. There is no such thing as a stupid question. Speaking of questions, please remember to use the chat function. We'll address your questions during the second half of our session. Also, look out for the comments in the chat. DFA staff will be helpful in making links and helping you in this session. So those are us, and we'll go ahead and get started. I'm going to stop screen sharing so I can talk to you, and you can all see my face and Len. Give me 1 second to stop the screen share. Okay. So again, my name is Kate Kelly. Just a little bit about myself before I get started. I am the committee chair for the Addressing Greed in Healthcare Committee at Doctors for America. I'm the immediate past chair of the Access to Affordable Care Impact Area. I currently am a family medicine board certified physician in Cleveland, Ohio at Metro Health, which is the safety net hospital in Cuyahoga County, which is the county that houses Cleveland. I have a doctor of medicine from Northeast Ohio Medical University and a master of public health. I wanted you to feel free to ask any questions. This is really a informal and formal presentation, but we really value your participation and we're really excited to have you all here. A couple of quick notes about the Greed in Healthcare Committee. The Greed in Healthcare work is housed under the Access to Affordable Care Impact Area. It's one of 3 areas that DFA works in. The campaign is a multi-year, multi-strategy cultural change program to promote a partnership in economic justice that includes a call for economic justice with a declaration that we hope fellow physicians, healthcare advocates, and organizations will sign on. We're actively recruiting for folks to be in this work, both as partners in our advocacy work and as organizations that you may represent that could be good partners for greed in healthcare. If you're interested in joining us, please put your name in the chat and Marlou will be able to help connect you. A couple of other notes on a personal matter that I wanted to share with you all. This work really began from a frustration on the part of many of our physicians that we felt private entity and profits over patients was really getting in the way of how we can care for our patients. I'm sure you've all felt this way. I'm sure you've all have been experiencing this. And I hear all the time from physicians who are frustrated with private equity buying out their practices or feeling like they are bound by insurance companies with the way they care for patients. And we felt as physicians that this was important to really center the work of Doctors for America, an advocacy organization that puts patient over politics, to be the leader in this movement. Additionally, Dr. Don Berwick, a very influential physician, thinker, activist, advocate, wrote an article in JAMA that was linked, I believe, in the original invitation to this talk that really talked about the underlying greed and economic driver of private profit over the health of our patients. And this was really a fundamental moment of change within our organization and within how we want to present ourselves to the world and protect our patients. Um, with that being said, there's a lot of work to do. We have a lot of minds to change. It's cultural and not policy specific, and we hope you can join us. We'll be working on messaging, on partnerships, on advocacy to really change the tide for folks and patients to really get better care. And we thought no better an advocate and speaker tonight as we kind of launch this campaign to DFA and to the rest of our community than Len Nichols. I'm thrilled to pass the baton to him. Dr. Nichols is a healthcare economist and a long history of commitment to healthcare justice. Uh, Len's career has spanned academia in Wellesley College and George Mason University, public policy research institutions from Urban Mathematica, New America Foundation, and government, the Office Management Budget and Agency for Healthcare Research and Quality, as well as the Federal Trade Commission. Since his experience as a senior advisor for health policy in the Clinton administration, Dr. Nichols has consistently added moral arguments to technical health and social policy debates. He is a popular speaker at activist and academic meetings. His current collaborative approach to public goods investment, or CAPGI, project at Urban Institute is a culmination of lessons learned while teaching, researching, writing, testifying, advising, and listening throughout his career. He has earned his BA from Hendrix College in 1975, his MA in economics from the University of Arkansas in 1976, and his PhD in economics from the University of Illinois in 1980. And with that, I am pleased to pass to our speaker, Dr. Nichols. He also has a lovely Arkansas accent, and so I hope that you all enjoy. We will give Dr. Nichols the floor, and then we'll open it up to questions and answers after. So please feel free to type anything in the chat, and I look forward to your talk. Dr. Nichols, please.
Thank you, Kate. That's a much kinder introduction than I deserve, but I appreciate all that. I'm really just a simple country health economist who happens to live in New Orleans now, my wife's hometown. But let me see if I can share these slides so you won't have to look at me during all this. Okay, can you see it okay? Great. Basically, when Ken Frissoff approached me to speak to your group, I was quite humbled and honored to be asked to do so. And he said, why don't you organize it around just, number 4, injustices in the U.S. healthcare system today. And I said, well, there are 40, but we don't have time for that. So I thought I would pick the 4 that seemed to me the most, maybe salient is the right word, maybe the biggest amount of money involved. I don't know, but in any event, that's the idea behind the talk. And I would define them, at least those injustices that stand out the most to me: access to mental health care, access to specialists, pharmacy prices, pharma, and prescription drugs. And then one that may seem a little odd, but I'll just say, as an economist, it's always bugged me, and I think it's worth pursuing sort of what it means: reserves of nonprofit hospitals, which are sort of a real thing. Anyway, mental health, I'm not going to give you a whole bunch of statistics. You guys know all this stuff better than I do. I just would call myself someone who can maybe make some lists that you can remember later on. Obviously, the slides will be shared. But when I think of mental health, I think about basically those people who do not have access to begin with. And of course, the uninsured are the ones who are most left out of everything. And there are still, 10 million uninsured people in the United States who live here. And so we know that that's a very serious problem. I will say, if you look at the last bullet, the withdrawal from insurance-related payments, the vast majority of psychiatrists that I know in Washington, D.C., and New Orleans, and for that matter, other places around the country, don't take insurance anymore. And so, in a way, we're all uninsured for mental health care. And I think the consequences of the combination of the systems that have produced this, which is partly driven by insurance and their unwillingness to accept the reality of mental health, and driven by psychiatrists' frustration with the way insurers deal with all the utilization review and ridiculous payment rates and so forth. It has led to this disconnect, so that essentially, if you're not well off, you do not have access to mental health in our country. It becomes most evident, that is to say, most salient in our daily lives when you see the people experiencing homelessness, and I'm sure, between a half and 2/3 of those folks have some kind of mental issue or substance use disorder or both. And of course, they end up, as do a lot of people, but they in particular have a lot of interaction with law enforcement. And so fundamentally, our inability to provide the mental health justice that we should leads to higher and higher costs and more problems in the rest of our society. Suicidal ideation, there's a personal story here I won't go into. I'll just say that it is deeply personal to me and my family. And I did look up statistics here. 1.2 million people try every year. About 50,000 plus or minus succeed. I will say those are both understatements, because a lot of the so-called deaths of despair or alcoholism or even car wrecks are really suicide attempts that are hidden from the way we count things. And so the point of this, of course, is to simply say our unjust access to mental health leads to all kinds of serious problems, which affect all of us ultimately, because we're all affected by the environment in which we live, where people aren't getting the mental health they need. Specialist access, this again is particularly salient to those people who are living with a relative or themselves having a complex problem. I will say, as an economist, it's important to remember relative market power is what determines relative prices. And the truth is, of course, as you all know, probably the specialists got control of the AMA process a long time ago when we were making the Medicare payment schedules. And so the specialists get paid a heck of a lot more than primary care. And the family practice doc, Kate, who ably led this webinar off, those specialist prices bake in a difficulty of access in general. And then when you add to it the fact that Medicaid pays so much less than Medicare, and again, you can look at different statistics, it's roughly 30%, and Medicare pays roughly 30% less than private insurance. So it's quite a gap between what Medicaid pays and what private insurance pays. And I will say that doesn't mean what private insurance pays is the right amount, but it does mean that Medicaid pays way too little. And of course, that's why the problems of access are greater for Medicaid, and you can imagine for the uninsured. FQHCs, primary care physicians all across our system report various degrees of difficulty getting referrals for specialists. Interestingly, and y'all can talk among themselves and explain why, orthopedics seems to be the #1 problem in getting referrals for folks out of those contexts. And of course, as you know, again, better than I do, the quality of care and outcomes suffer for complex patients. I can tell you lots of stories, but you know them as well as I do. I'll just say, in the absence of access to specialist care when it's really valuable, you end up doing subpar things that either cost more or make the patient suffer more or reduce the quality of life, which is the fundamental point. On pharma prices, I could go on for decades here. I'll just say the facts, and they are that if you look at pharma companies versus non-pharma companies in the U.S. economy, the rate of return is about twice the average rate of return, profit rate, whatever you want to say, margin of other companies in the U.S. economy. And you probably know, if you don't, you should, pharma has the highest margins in healthcare by far. Their margins are roughly 17 to 20%, whereas hospitals are typically 3 or 4, insurers are typically 4 to 7. So, they're just way higher than everybody else. They spend more as a consequence on lobbying and campaign finance, of course. And I'm sure they fought tooth and nail against Senator Wyden, the senator from Oregon, who has been leading the charge for some time, trying to bring about Medicare negotiation. We finally got a modest element of that in a piece of legislation that just passed. All the pharma companies have declared it unconstitutional, and they filed suit in court. Yet they agreed this week to participate. So they'd like to get the money, but they're also going to say it's unconstitutional if they can. They want no part of any kind of governmental interference in their ability to charge what the heck they want. An interesting fact that is not well known is that for most large commercial insurers today, pharmacy spend is actually higher than hospital spend, which, if you think about the big pie of national healthcare spending, That's a stunning fact. And it means that pharmacy is taking more and more and more of the healthcare dollar. And of course, these margins mean a lot of that is unnecessary. Meanwhile, of course, two simple examples, diabetics can't afford insulin, and cancer is basically a diagnosis of bankruptcy. Now, let's see if I can make this do right. This is the beginning. This is a really interesting article, just came out a couple months ago on nonprofit hospitals and their cash reserves versus their charity care. And here's the chart that makes the point. I'm not sure you can see my cursor, but if you can, the first 4 columns are for nonprofit hospitals and the last 4 columns are for for-profit hospitals. And what this research study did was compare basically averages and standard deviations from 2012 to 2019. So it's pre-COVID, post-ACA implementation of coverage expansion. And what you see is that these are averages, so means across all hospitals in this category, nonprofit, for-profit. Operating profit is roughly 43 million on average in 2012. It's gone up to 58 million. Charity care didn't go up at all statistically, or in fact went slightly down, absolutely. And I will say that wasn't shocking because uninsured went down between 2012 and 2019. But interestingly, look over at the for-profit. For-profit charity care actually went up from 2 million to 6.3 million, which is kind of interesting when you think about nonprofit not moving at all. But here's the point I'm trying to make. Cash reserve almost doubled, even as operating profit went up about 20%, maybe 30%, and cash reserves doubled. And look at the standard deviation here. There are some very wealthy hospitals who are basically socking away cash and investing it in all kinds of ways, and I would say in ways that are not related to patients versus profits. Okay, so think about what hospitals and health insurers, for that matter, could do for social determinants of health if we moved our system to paying for health and not for health care. And that's sort of obviously where I want to go. Policy must change to enable this, but I would submit it is possible. So to summarize my would-be simple remarks, I would submit we tolerate injustice because we think we can't change it. We tolerate it out of fatigue and what seems to be intractable policy barriers to change. And that's why I'm so supportive of Kate and DFA's attempt to marshal physician credibility to improve the conversation at the national and the state levels. Tolerating this injustice like we do means, in effect, we accept that some lives really are worth less than others. And I'll just say, that's what happens when you give up, when you say, okay, we can't change it, we just got to live with it, it's the way it is. Solutions here are not really that complicated. They would require changing the way we pay almost everybody, but there are a lot of economists who would help you do that. I'll just say it will create winners and losers. It is not, however, that difficult to figure out how to pay what adds value and pay less to those things that don't add value. The question, and the fundamental question, I turn back to Kate and you all, does the political will to challenge the lobbyists that have preserved our system and created it, does the political will to challenge them in unprecedented ways really exist? That is the question you all have to answer, and I hope we all agree on the answer. So I will stop there and let Kate take it away.
Thanks, Len. Please put all any questions you have in the chat, the Q&A part of this webinar. It's really the best way, and we'll be sure to get to everybody if we can, given time. Thanks so much, Dr. Nichols. I think, part of what you laid out was really what we're trying here at DFA to fight against. And, turning away from caring for patients and instead lining the pockets of shareholders. And I think we've all experienced that. If, any doctor on this call, when worked at a hospital, they've seen the top heaviness of administrators versus those who are actually doing the work, and not physicians as much as, LPNs, MAs, et cetera. So kind of to summarize what you talked about, I don't want to mischaracterize it, so please correct me. We have a couple of major issues. One is mental health. and the difficulty with accessing mental health care, including care for the unhoused and the social determinants of health. And then really addressing the profit-driven model for healthcare corporations, including hospitals, medical device companies, pharmaceutical companies, and even those who call themselves nonprofit, and really calling out the nonprofit versus profit misnomer, if you will. And then the final question is, do we as physicians have the power? Do we as healthcare uh, consumers have the power to really push this political and policy change? And I'm sure many of the people on this webinar will also agree, what can we really do? So
Very well
please
said, Kate. You
share
should
your
summarize it
questions.
more often.
Well, I'm a family doctor, so I'm used to 20 minutes in a summary statement. So we have some great questions in the chat. The first one is from Greg Bounds. Mental health insurance coverage is confusing to me. Didn't the ACA require ACA compliant insurance plans to cover mental health services as an essential benefit? Why is access still poor? Is it mainly the withdrawal from insurance related payments?
So really good question. And the first answer, I think, has to do with the reality that mental health parity is kind of in name only. The idea is that you cannot make people have higher copays or longer waits or whatever for mental health than you can for physical health. That's in the law. So technically, those barriers have been removed. But, big but insurers say, psychiatrists won't join my network. What can I do? And psychiatrists say, I don't want to join your network because of what you make us go through. And so you've got this impasse, and that you don't have the supply that you need to make mental health parity a reality. So what I mean, there's lots of reasons I would submit. One of them, and perhaps the most important, is the actuarial view that a lot of mental health is not effective is still prevailing in the way the insurers organize themselves. And we can argue about what is and is not effective and what is and is not improvement. But I will just say they still think everybody's Woody Allen's whining cousin. And because of that, they keep rates really low. They're extremely tight on authorizing 6 more visits, whatever. And it drives psychiatrists crazy. It completely interrupts everything Kate talked about, appropriate patient care. And a lot of psychiatrists, in fact, again, I would submit most of them have figured out they can make a fine living, thank you very much, just charging the higher resource people what they want to charge them. And that's what most mental health is for the middle class population and upper middle class population. We still have crisis mental health, and we still have, ways to deal with, if you're actively suicidal, show up in an ED, we will put you in inpatient psych ward for 4 days. That is true, right? And we will keep you safe for 4 days. Then we turn you loose and we say, good luck. And so what we don't have is any kind of, I would say, a serious attempt to make access real at the point where it really matters, which is when people need it. So there's a lot of work to do, but to me, it's making mental health parity work. It's not going to work until insurers and psychiatrists have to agree on how to make conditions reasonable. And that's not going to happen as long as the actuaries are driving what's going on.
Mm-hmm. Yeah, I think, the county hospital I work in, I think we see that all too well. A follow-up question to that, which I think you answered, is Jim asked, the uninsured for mental health, how you kind of said that is so well put. Can you expand on that? What are the underlying reasons? And I guess if I could extrapolate from Jim's question, is it the greed of practitioners that want to make that $500 an hour in private practice, or is it really a breakdown of the system with the reimbursement rates are too fair or are unfair to those providing mental health care?
So I would observe that the low payment rates is what drove the psychiatrists away from insurance. The low payment rates and the hassle of getting their patients allowed to visit for 6 more times or 12 more times or whatever they thought at the moment. It was sort of the administrative hassle and the low payment rate. Then they discovered there's a market out there because the demand for health insurance, mental health care is so great among people who have money. They discovered they could charge real money. And so, but if you look at at least the AMA's income statistics, I don't know of anyone who does a better job, unfortunately. So fundamentally, they still don't make that much compared to the interventional cardiologist and the orthopedist and yada yada yada. So I don't think it's they're charging too much per se. I think they were driven away by the insurance attitude that mental health is not effective, therefore we want to shut it down.
Yeah. Um, it's like it's very, I mean, I work in the addiction medicine world and it's extremely difficult to find a psychiatrist, as everyone on this call knows. So Robert asked, what do you think of requiring hospitals to invest a percentage of their reserves in CDFIs in their market area as a regulatory requirement?
Wow. Well, that's a really provocative and specific question. And, hey, Robert, I'm in favor of rules big time. I'm not certain I would say you have to spend it on CDFI. CDFI is a community development financial institution. It's the thing that invests in local housing and basically anything that improves the community as a whole. And they tend to be sort of subsidiary financial institutions, and some of them have done great work around the country in various places. I'm not opposed to that. What I would do is give them a choice. I would say you got to spend X% of revenue, period. And that can be spent on SDOH. It can be spent on community CDFI. It can be spent on your own. You know what? A whole lot of hospitals are having trouble hiring people because they can't afford housing where they live. And so building housing for, let's just say, sub-RN level workers could also be housing for local people who are not sub-RN workers, but they are indeed other kinds of workers. So you could imagine a world in which the requirement to spend a certain amount of revenue in the community could be given flexibility. Yes, you could turn it over to a CDFI, but I think you'd be better off if the hospital actually directed it toward those things that are more likely to affect both their workforce and the health of the people around them.
Great answer. I think, if we could expand housing, I think we would do a lot for health. Greg asked, there was a recent provocative perspective article in New England Journal of Medicine, or JAMA, about spending healthcare money on healthcare, not social determinants of health. The author felt other money should be dedicated to social determinants. What are your thoughts about this?
So Sherry Glee's a friend of mine, and she's a very good writer, and she's very smart, and I would say she's providing a perspective that I think can be characterized as saying healthcare's got enough issues. Don't be adding to us the utopian dream of having everybody get what they need in the social service sphere. I sort of understand the impulse and I understand the gut reaction. In my opinion, it's misguided because while healthcare cannot solve all social problems, healthcare is uniquely positioned to observe people who need those social services to enable them to become healthier. And if you cut healthcare out of that equation and depend upon housing money and food money, and I might observe we don't have enough housing money and food money coming anyway. So why not let healthcare get more involved? Again, it does not mean healthcare should pay for all of it. And I don't mean to say we should divert every healthcare dollar upstream, to make perfect housing and have crappy hospitals. No, what I'm saying though is that I want healthcare involved, very deeply involved in deciding how to integrate social and medical care, because that's how you're going to have a healthy population, not acting like, well, just depend on HUD for that. Because, for whatever set of complicated reasons, we decided a long time ago, and now with the ACA, we decided kind of big time, every American has a right to decent health care, not great insurance, but decent insurance, I would opine. And that's a bigger deal than we've ever done for housing, or for that matter, food and transportation. And so I would say we don't have enough money in general. Healthcare knows how to direct money specifically. Healthcare probably should hire it and not do it themselves. The last thing you want is a bunch of doctors and nurses going into people's houses. What you want are community health workers, maybe social workers. Don't send the economists either. We're worthless. But the point is, you want people who understand the consequences of the social deficits, and that's what healthcare does, because healthcare sees it every single day and night.
Yeah, I mean, I think if we're de facto doing that anyway. I mean, the ED of the hospital I work for, I'm sure many people on the call have had this experience, is a de facto shelter for many folks, especially in the cold Cleveland, Ohio winters. And we can't help as people that have taken a Hippocratic oath to help and things that are outside our sphere, including housing, including food, including transportation. I mean, how many of you have written forms for bus passes or
Yeah.
written a bill to provide air conditioning for a patient who has asthma or not to get their electricity cut off? Like these are things we're already doing, and it's time that I think the budget really reflects that and treats healthcare as part of that system. Jeff asked, to what extent are the inequities in healthcare just a smaller part of the overall tolerance of wealth inequity or inequality through neoliberal economic ideology in USA culture?
Well,
Woo!
it's pretty hard.
Okay, great question, Jeff.
Yeah, I mean, look, there's no question, Jeff, our tolerance of inequality comes from a set of beliefs that it's either just as a result of effort or whatever, or there's nothing we can do about it. Before we with you always, sort of fatalistic view of religion and civilization. Um, I think at the same time, it's important to emphasize a lot of people are not accepting this, and about 47 of them are on this call. I mean, I do think there's a lot of people around the country who don't want the kind of inequality we see. You may remember the Harvard sociologist Robert Putnam wrote a book a decade or so ago, Bowling Alone, and he sort of summarized the decline of civic participation in the United States. He's got a new book, and it's called The Upside. And what he does is he compares today's complete everything that's wrong with us today. He compares it to 1890 to 2010. I mean, 1910. He says basically we're living through another Gilded Age. And what did we do back then? Well, first thing we did was we sued John Rockefeller in the antitrust suit, and we beat him. Guess what? The FTC just filed against Google and Microsoft. I mean, these big companies are and Amazon. So fundamentally, we're starting to do this. And his point is we can do this again. We can come back from gross inequality and gross because most of us actually don't accept it. It's just that it seems like everybody accepts it because we don't really try to change it. And our politics are broken, and we'll talk about that later. But we may need more liquor to get to that part.
Well, you are in New Orleans, so
Yeah. So yeah.
um, yeah. Uh, is there a good source to get reliable history about the role of physicians and the AMA and the current payment structures? This is from Sarah Hartfelt. What about the makeup of the committee at CMS? I
So
think you're talking about the Rock.
the ruck, yeah, the ruck has definitely been captured by the specialists of the AMA for as since Civil War, no, since it was created in '89. But I think honestly, what I would do, and I'll put his email in the chat. You want to send an email to Bob Berenson at the Urban Institute. Bob is kind of like, I would say, the guru of physician payment in the United States, and he's been around a while, and he can point you to and tell you what you need to know. And I will put that in the chat right now. Well, maybe a little later. Maybe I'll send it around later. That's the best thing to do. But yes, there are people who can walk you through this. Essentially, it did have to do with the way that, when we set up the Medicare program, we basically said, okay, we're going to do what Blue Cross did in 1965 because that's all we knew. And what did Blue Cross do? They paid usable, customary, and reasonable, which meant what actuaries thought was reasonable, which had to do with basically a probability distribution of what came in over the transom. When Medicare started doing that, they had to publish it. Blue Cross had kept it secret. And as it got published, more and more doctors said, well, hell, if he's charging that. And so prices went up really fast. And that's when we made a fee schedule. And the fee schedule was designed to stop the inflation. And the fee schedule, however, got captured by the people who were in the AMA. And the majority of people in the AMA, even then, were specialists. And that's exactly why specialists get paid a heck of a lot more than primary care and will until you get control of the ruck. So hang in there and ask Bob and act accordingly. I'll say that.
Howard asks, many opponents of publicly funded single-payer universal coverage claim that they fear that the plan will not provide the services they want and want there to be an option for private, i.e. enhanced coverage. What should our answer be to that?
Well, it is a fear. There's no question that people in the United States, in particular, are afraid of government limiting. You may remember at the time of the ACA, at the time of the Clinton plan, all this stuff about death panels, and
Mhm.
they're going to say no and won't let us have this and that. Interestingly, they tend not to mind when private insurance says no. But I'll just say, look, it all comes down to what are we willing to pay for? Okay. A single payer plan doesn't have to be parsimonious any more than United Healthcare's Cadillac plan for the executives who run United Healthcare. It has to be parsimonious. It all has to do with what are you willing to pay for and how are you going to organize the payment system to get the results you really want and make sure you've got the healthcare workforce and technologies and so forth that you really need. So I don't think there's any reason that public payment versus private payment is going to be higher or lower. It all has to do with what are you willing to pay for. I mean, I look at Germany; they don't seem to be having trouble getting specialist activities. I look at Switzerland. I look at France. I look at, now England's had some issues with rationing. They probably spent too little for some time. Canada is somewhere in between, right? Canadians come to the United States to get elective surgeries because they can get it quicker here and so forth. So there are some issues, but that all has to do with what are you willing to pay for and how are you willing to organize your system. So it's not inherent to public. It has to do with how you want to organize your system, but you do have to organize it completely if you're going to avoid those kind of disparities.
Len, I think that, you know, patients love the idea that they're the consumer, and we've really internalized this as Americans. And um, it's hard because in my practice, I've had a lot of people who are frustrated with the care they received, and their answer is not, wow, what a shame that our system is so underfunded. Their answer is, well, I'm going to go to hospital X down the street. And people really, as Americans, have really internalized this idea that they're a healthcare consumer, which has been pushed. So I don't know if you have an answer to that
I
type
don't
of
know if there's an
internalization of
answer, Kate.
capitalism.
I don't know if there's an answer, Kate. I would observe Americans are very deeply, you might even say, conditioned to accept individual responsibility and to accept, like, it's us, it's our problem, it's not a social problem. And so I want to go to the hospital down the street. I want to change health plans. I want to get a different doctor. All that has to do with I'm going to solve my problem and I'm not going to worry about the bigger system. And that's the way we're taught to think. Way it's kind of in our water. But at the same time, that's kind of what's interesting about, in my view, the current moment. Look, the whole movement toward the ACA was a movement of saying we cannot be on our own against insurance companies. We will never win if we do that. And that's why we have insurance regulation much tighter than ever before. Before, they could discriminate against you if you had any health condition at all and not even cover it. And you had no power to change that as one person. So you need to have rules to make the market work more fairly. And those same rules can affect any part of the system you want. It's just you really have to get a comprehensive approach to changing the rules. And I don't think it's rocket science. It's not simple, but it's a whole lot of people can help you do it. And you guys know everything probably needs to be changed. But I think fundamentally it's about being clear about what people deserve, how you're going to organize the system to deliver it, and then how you're going to pay people fairly to get them to deliver it. And then you got a sustainable system. I would just keep looking around the world. There's lots of places where they're doing it better than we are, and we could learn from them. And they don't have the same, I guess you could say, intense individualism. They don't believe they're supposed to solve the problem by themselves. We
Mhm.
can work together. We just have to remember how. We've done it before.
Bill, great response. Bill asks, is there a legal obligation for nonprofit hospitals or HMOs to provide charitable care? Is there any states that have laws requiring a percentage of profits to go to charitable care?
So the federal EMTALA, which is something like Emergency Medicine and Active Labor Act, requires hospitals to stabilize a patient. So you come in and you've got a broken arm, you come in and you're bleeding, they have to stop the bleeding, they have to splint the arm. They do not have to treat the cancer. They do not have to give you everything you might need, but they do have to stabilize you. That's what is required. Many states have laws that say you've got to sort of tell us what you're doing on community benefits. And you may recall the ACA had a requirement that all hospitals in the United States, all nonprofit hospitals in the United States, which is the vast majority of them, have to have a report of the community health needs assessment, and then they have to say what they're doing about that. They do not, as far as I know, no state requires anybody to spend X% on those community benefits. Pennsylvania played with it for a while. California played with it for a while. I don't think anybody ever actually pulled the trigger and requires it. And so that's a place to start, because the ACA laid in the foundation of, okay, now we know what everybody knows the needs are. We knew that before, but now we got to document it. And we can compare what the hospitals are doing. I will say, all those reports are interesting. COVID came along and it really did kind of knock hospitals for a loop, and you can't blame them for that. And now, given everything that happened with the workforce during COVID, essentially the nursing workforce now costs 20% more. And so hospitals are not in great shape at the moment because of all the sequelae from that. And so they're not keen on having a new spending requirement imposed tomorrow. So maybe you don't want to do it tomorrow, but you do want to do it over time. And you want to think about, again, what's the best way to marshal those resources to maximize the health of the communities in which the hospitals sit. And I would argue that's given them some kind of SDOH or CDFI or some kind of community benefit requirement. If it's the same for all hospitals, they can't claim competitive disadvantage, and you can kind of go from there.
Correct me if I'm wrong, but I do think there, at least in the state where I live, I feel like there is some restriction on how you can call yourself a nonprofit
Well,
and
sure.
how to reinvest that money.
The nonprofit typically has to do with, you have to agree to provide charity care under certain conditions for certain people. Okay. But what I'm trying to say is every serious analysis I've ever seen of it shows they're getting way more of a tax benefit than they're giving away in benefits. So we're not getting our money's worth. Let's put it that way. And
Yeah.
it's kind of interesting. The for-profit hospitals actually come out looking better in some of those studies. It's kind of shocking, but it's true.
This is a great question. How do we start the conversation between primary care and specialists when the pie continues to be the same size?
So that is a good question. And if I knew a very succinct and pithy answer, I'd be a very rich man. But I will say that, at the end of the proverbial day, it's kind of like, I mean, not to be too heavily reliant on sports analogies, but it's kind of like, how much do you pay the quarterback? Okay, versus the tackles and the ends and the so because you can't have a quarterback won't live very long without the other people blocking for him. So you've got to have a team. So to me, the way to solve the problem is to think about what should the team be paid, and then how do we decide relative worth of the team members. And I would argue within the team itself, there's actually not that much dispute. It's disputed when you get team A versus team B buying for the same quarterback and that kind of thing. But at the end of the day, everybody knows exactly who's worth more. And everybody knows that those people at the bottom of the food chain right now ought to be paid more. And you know what? If we did that, we might not have the Kaiser strikes and that kind of stuff going on. So fundamentally, it's about redistributing the pie, but in a way that people agree with. Now, does that mean an interventional cardiologist will make the same money made this year? No. Does that mean an interventional cardiologist won't have arguably a better, more enthusiastic team and maybe a better life? I would argue it's entirely plausible. I know surgeons who have done less surgery and been much happier when they reorganized the way who got to them, what the role of PT was before patients got to them, and what kind of patients they were operating on, which improved both the efficacy and the long run health improvement, and made them all happier, even though they made less money. So there's more to life than money. I know it's hard for an economist to say that. And I'll just say, somebody making $3 million a year probably doesn't need that. They may feel like they've already bought their 3 homes and they got to maintain their mortgages. So you may have to have a transition period. But I'm just trying to say, have a conversation among the team, pay the team and let the team figure out, because the team can't work without all of them, and that's how you make it work.
Money doesn't buy happiness sounds definitely more like a psychologist than an economist. So if you want a career change, I think you're in a good place. This is from Ken, first off. Some advocacy organizations focus exclusively on the greed of insurance companies and private equity, which focus more on money than healthcare. How do you think it is possible to be critical of all greed-oriented subsectors in American healthcare?
Whoa. Well, so it is interesting when you think about, what is enough? What is the goal, right? And I have met people who run physician practices who say the goal is for my docs to make as much money as possible and provide excellent patient care, yada, yada, yada. And I would just say, if that's your metric, maybe, and that's what Berwick wrote, maybe this is the wrong business for you, right? And maybe what we should do is, if you think about my team conversation, which ultimately gets enforced by regulatory rules that Medicare would have to agree to, it may not be possible to make this much money doing this stuff anymore. And if that's what you're in it for, I think we can probably do without you, because I think there's plenty of people who are doing it for the right reasons, who are now so frustrated at the way this thing is organized, they would gladly step in and do this stuff. Now, maybe we'll lose some brain surgeons, maybe, although I doubt it. Maybe we would lose some interventional cardiologists or orthopedists. I don't know. I kind of think they would grouse and live with it. But I do think it comes down to, everybody's got to believe the equilibrium is fair. Okay.
Mhm.
Right now, I don't think a whole lot of people think it's fair. And even those who are at the top of the food chain, they know it ain't fair. They're just taking what they can while they can. So if you're going to have a conversation about making it fair, I don't think they would all run screaming from the room. But if they do, well, then, we'll have to deal without them. They'll be okay.
Uh, yeah. Well, we'll cross that bridge when we come to it, right?
Yeah, we're a long
So
way
from
from there. That's right.
This is from Pat Herndon, and I think this is a great question, something I think about a lot. What happens when you change the fundamental nature of healing systems and institutions into a public utility?
Wow, that's a really philosophical question. And I would say it in a way, public utility calls to my mind anyway, the notion that everyone has to have this. It's an absolute necessity for living: water, electricity, food, whatever, broadband today, whatever, safe streets. But turning healthcare into public utility is changing the nature of that individualistic relationship between the patient and the healer. That is true. It does not mean, in my mind, it would be impossible to maintain the fundamental sacredness of the relationship between the healer and the patient, because the healer and the patient are still in relation to each other. What's different is who's paying whom, and how much they're getting paid, maybe, and what the rules of engagement really are. I don't know why you couldn't write a better public utility system than we've got now. If you get, we used to joke, the fundamental assignment in Health Economics 101 is design a system this badly for any other part of the economy, and no one can. The incentives in healthcare are completely screwed up. We can't do worse. We could do better, but we got to be careful. And it seems to me all the lessons you guys know should be baked into utility conversation. But it's a very good question, because it makes you mindful of the fact you're giving up something when you move away from that individualistic ethic, and you would be moving to a more social ethic, and you just got to be careful when you go down that path.
Right. And everyone likes the idea of a public good. So we
People
have
are
time.
afraid. People are afraid of change. That's right. Yep, yep, yep.
Yeah. The change is healthy. So just put, as doctors, we know that, right? So two more questions, and I just want to point out that we did have a question in the chat that says, an economist making house calls made them smile. So uh, we can go at house calls together. I like that idea. An economist and a family doctor walk into a room. Um, but someone had asked about the Kaiser strike, and they said there's 75,000 employees on strike. I wonder how many physicians were there. We talked about it briefly before, and I don't want to get us too derailed in the last couple of minutes, but maybe this would be a great time for you to give us your take in it as a health economist.
So I think it's interesting. No doctors are striking, no nurses are striking. People who are striking are either pharmacists or optometrists in the East Coast, or what I will call nurses' aides and folks like that from techs out west. And it has to do with, I would argue, the people at the bottom of the payment food chain saying the working conditions that they've been saddled with since COVID have been intolerable for years. Everybody's burnout is real, and it's true up and down the healthcare workforce. You all know this deeper than I do. And they're saying, look, I don't feel like we're doing good patient care. I don't feel like we're doing safe patient care, given how our units have shrunken and we're being forced to stay in here and just basically do more with less. And so, and they're asking for more money, but that's almost like a secondary thing. They're really asking for a reorganization of the healthcare delivery system. And that's why I think it's a different kind of strike than we've had before. But Kate, you may have a take different.
No, no, I agree. I think just finished residency and there's a big movement for residencies to unionize. And I think it has to start small. And I think doctors are fearful of their positions because they aren't protected. And and I think the state I live, attending physicians can't unionize by law. Don't quote me on that if anyone lives in the state of Ohio. So I think it's encouraging to see that people aren't going to stand for the substandard working conditions and best patient care. Um, so finally, this is kind of a question that's been in the Q&As with kind of sprinkled in through a lot of folks. And really the big question, the big take home from this event, which we are so glad that all of you joined in. We've had so many questions. And as this is our kind of kickoff event to work on our Addressing Greed in Healthcare and Economic Justice campaign. And for those of you who want to join us, we're thrilled to have you. We're working on a declaration about this. We're working on partnering with other major national organizations who serve patients and represent physicians. We'd love to have you work on messaging and partnerships and getting the word out and educating your fellow colleagues in healthcare, friends and neighbors. But how can we how can physicians empower patients to get involved in changing the broader injustices we fall victim to? And also, how can we get more people to vote and change some of these policies? What's next, Len? Like what can we do? We're all frustrated, we're all at our wits' end, and we want to change.
So, well, first of all, you do what you're doing. I think you organize Physicians' Voice, and you organize Physicians' Voice to speak very clearly about what your priorities are and why the current system does not permit you to deliver first-rate patient care, which you know you're capable and we're capable of delivering to our nation. So first you articulate what the hell is wrong. And then I think you enlist your patients as your allies. They know you are their spokesperson. They know you are their best friend in their troubled health management. And the vast majority of us still trust our docs. I mean, I've always said it's because we get naked in front of you, we have to trust you, but still we do. And so because we trust you, then you got this thing. And let me tell you what, trust is a scarce asset in our country right now. So build on that. And I would say everything y'all do together, do with patients. That amplifies both your voices, and do it with nurses and do it with students and do it with, I'm just saying, movements grow from that kernel of trust, and trust is an asset that will grow if it's shared. So demonstrate to the world how your trust is being manifested and why you're co-advocating for changes in the system. How do you do it? Well, look, there's 10,000 ways, and right now in Washington, I wouldn't recommend you drive down there this afternoon, but I would say you focus on people, and there are some in Ohio, and there are some from Ohio, and there are some in every state, actually, even Louisiana, that know what the hell we're talking about and are in a position to listen and do something about it. So I think you talk to your elected representatives, you try to get people elected who are more sympathetic. But you start with what you got, and you start with the trust you've got with your patients, and you show these people why we have to change and why their own care is threatened if we don't. I think that's the message that almost every, and let's be frank, older congressman or senator will relate to, because they're pretty worried about their own health every single day.
Yeah, I think that's a really great note to go out on, Len. I think we sometimes underestimate our power as individual physicians when we can come together. And trust of a patient and trust of the public is really an honor and a privilege. And it is our duty as physicians and people who took, an oath to care for patients to really take that seriously and to continue to advocate for our patients in everything we do, both inside the exam room and outside the exam room. Um, Thank you so much for your time. We have 2 minutes left. Any takeaway points before we log off? I feel like a psychiatrist, our time's almost up, but is there anything you can leave us with before we hop off for the evening? And again, for folks that are interested in this work, interested in joining us in DFA, we have a lot of different impact areas from abortion access to gun violence prevention to COVID relief efforts. We'd love to have you join us. If you feel angry and you want to change, DFA is the place for you. So, Len, any final thoughts before we end the
Oh,
grand rounds?
I think both of us have said it. I would just say, never underestimate the power of your voice when you join it with others. And you guys have unique credibility and everything you're talking about and all those issues Kate just mentioned, and just go forth and say it loudly.
Awesome. All right. Well, thank you, everybody. Thank you again to Len for joining us. We really appreciate you taking the time. And we'll be in touch. And please fill out the CME form to get credit. If you need anything, feel free to contact us directly, and we will talk again soon. All right. Have a good night, everybody. Thank you.